Hello and welcome to CDA Oasis. My name is Shiraz Ghesayeh. I am very pleased to welcome our creative contributor to CDA Oasis through his mentorship series, Dr. Paul Belzicki. By now, most of you know that Dr. Belzicki is a dental surgeon from Toronto in private practice for close to 4 decades. What you may not know, and for which we are deeply grateful, is the amount of time and effort he dedicates to create these valuable CDA Oasis knowledge nuggets. Today, he is here to present a very interesting case, and I'd like to welcome Dr. Belzicki once again to CDA Oasis.
Good morning, Shiraz.
So, Dr. Belzicki, can you, before we go and see the case, can you tell us a little bit more what the case is about and why is it important?
Well, as neat and clean and as certain as we strive to be in practice and we want treatment to proceed in a timely fashion, life does tend to throw us curveballs. It's messy. And sometimes treatment doesn't go from A to Z in a neat fashion. And this patient presented to me with a lot of dental problems. And often when this happens, I think to myself, like, what went wrong? How did it get this way? Like, what combination of psychosocial, physiological criteria are at play for a person to end up like this? And in this case, she came to Canada as an adult. She was originally from Poland. They didn't have the best dental care back then. And like my task, I feel, as a healthcare provider, is to try to tease out these issues to manage the case effectively. How did it get to this point? Let me not retread past mistakes and try to figure out what's the best way to provide treatment. And sometimes with these complicated, large cases, you don't even know if you're going to get to first base. So how the treatment progressed in this case is interesting, how it played itself out. And I kind of laugh sometimes when I see these advertisements, teeth in a day. Like, the simplest thing in my office takes teeth in a week, or at least a month, and sometimes a year. And in this case, it took a decade. And it's just kind of interesting how it played out, and the fact that it turned out successfully. And finally, I'd just like to mention that I'd like to thank this patient for allowing me the permission to present this case, use two of her facial images, because it's important in some of the technical aspects of the case. So it's interesting.
Yeah, I must say the title intrigued me. Teeth in a day, really? So I wanted to know a little bit more about it. So shall we go and see the case?
Yes, we shall. Hello again, boys and girls. Paul Belzicki here. Let me tell you, for those new to me, I'm a general practitioner. I provide periodontal surgery, endodontics, and restorative dentistry. And I endeavor to integrate these protocols to deliver long-lasting restoration in terms of decades. And my motto is doing it old school. And today's theme is teeth in a day? Really? When I hear of claims of teeth in a day, I think to myself, typically in my office, it's teeth in a month at a minimum, or teeth in half a year, or even a year, and sometimes in a decade. And this is such a case. This woman presented to me in 2006. In May of that year, female, about 40 years old at the time, with no medical issues. She was originally from Poland and didn't have the benefit of what we would term modern day dentistry. At the time, she came here as an adult and missing a lot of teeth. And as you can see, a very deep overbite, crowding, and just did not like to smile. And she said, I hate my teeth. That's why I'm here. I have no pain. My joints are fine, no clicking, no popping, no other issues. I just hate my teeth and I never smile. So taking my records, I take all these photographs and radiographs, and I could see every tooth has a story. Everything's been heavily worked on. Endos that were done, not quite to North American standards, but no pain, no discomfort. You can see here amalgam, composite resin, a hodgepodge of materials. Tooth 45 was tipped badly towards the lingual. So there are a lot of issues to address. And so first things first, when I document these cases, I need to take study models because I have to document what the starting point was and keep that. Also, in taking stone models and looking them over, I get more of an intuitive feel of what I'm up against and what the problems are. And in this case, she had a very, very deep overbite and a lack of posterior support. There was some, but it wasn't great. So I knew I need to establish a stable occlusion for any long-term success. It's just not a matter of, can you please just fix up the 4 or the 6 front teeth. This was a complex case, and I know that complex cases are a composite of many small problems that need to be addressed in a proper sequence and managed to suit the patient's psychosocial, physiologic, and financial criteria. And in this case, there was an emotional overlay regarding her dentition. She hated the way she looked. She was a smoker, and finances were not unlimited. So this isn't a formal letter of consent. This is more of my thoughts because there's so many problems that I need to address, and I have to wade through all of these problems. But typically, I will make a letter like this to a patient. I'll embed some of the pictures and number the teeth so they can follow along in the roadmap. Now, I'd just like to read the last paragraph that is written to her. The above is a basic outline with estimated costs for your consideration. There are several permutations of treatment options. One is orthodontics to open the bite and reduce the crowding. Other treatment options involve implants to replace lower molars. Although the above is complicated, you must be made aware of your dental problems and all treatment options. It is my intent to provide you with this information to form a basis of discussion should you wish to continue with treatment at my office. So at this point, I didn't even know if I was going to get to treat this case. I just felt that this was just fact-finding on her part. I didn't see her for 5 months later, late in November, when the bicuspid had broken. So that tooth was extracted. And she didn't return for 2 years. I thought I lost touch with the patient. This was just one of those that was going to go nowhere. But she did return November 2008 with pain from the lower anteriors. And you can see that the bone level has dropped substantially between these teeth. As a result of just neglect of basic care at a dental office. So again, 2006, and then in 2008, I had to extract the lower anteriors, and I used these 3 teeth as retainers for an immediate provisional bridge. And there I fashioned it out of methyl methacrylate, Durahue, powder liquid, put a little bit of pink resin there to try to fake out the eye, did a little bit of gum surgery to clean up the area, and that's how it presented a month or so later. And it looked quite reasonable, and she was comfortable. I had to do an endo in 234, and it did split off halfway down the root, so that was an interesting case. 7 months later, she returned. Later in October 2009, she had fractured some of the restorative material off of tooth 21. And well, we've got to go with crowns in this case. You can see that every tooth has composite resins in it, and some of them are failing. And I thought the best way to handle this was with provisional crowns. So taking my stone model, adding a little bit of light cured blue blockout material, draw a shade of plastic over it, and go to the mouth and start fashioning provisionals. And I trim all these up with a sandpaper disc in a slow handpiece, an electric handpiece, and just fiddle with some of the parameters of interpupillary lines, lip lines, and slowly develop what I thought were aesthetically pleasing anatomy. And here I knew that there was a discrepancy in the gingival contour. I didn't know whether endo was going to be possible at this time for her. I certainly didn't want to cut away tissue here for the sake of making them equidistant. That would end up with another problem. So what I did was trim some of the acrylic away that was tooth colored and added in some pink denture acrylic. And a year later, she returned, and it was looking quite reasonable. I had gotten her off to an orthodontist who managed to put some brackets on these teeth in order to provide traction and pull tooth 45 into a better alignment so I could put a bridge there. So between 2009 and 2010, I addressed the lower left, I put a bridge in the lower left, and the ortho was done. So you can see, going from 2006 to 2010, I've uprighted that molar. Yes, I was aware of the less than stellar endodontics that was here, but the bone level looked fine, or the bone periapically looked fine. Trying to take this apart and redo this, I worried about the risk of losing an abutment that I dearly wanted to have. So no decisions were made at that time, and I would just monitor it, recalling that these endos were done decades ago back in Poland. So I re-cemented those teeth sometime in 2011, and then I lost touch with the patient, and so did the orthodontist. He kept calling me, where is she, where is she? And I said, I don't know. We're trying to contact her. She does return the calls, but there are problems, there's family issues that mitigate against her coming in for treatment. So neither one of us saw the patient for the better part of 3.5 years. During that time, some of the bracketry had fallen off, she'd lost the wire. And this is why I love methyl methacrylate powder liquid tooth resin, and you should too, because after all of these years unattended, this has still held up. Yes, it's beat up, but it still has secured the teeth. I've even broken, she's lost one of the pontics there. But most of the acrylic is still there. And when I tugged off the temporaries, which I had cemented in with poly-F cement, polycarboxylate cement, that cement adheres to tooth structure. So the temps came off cleanly, and I could see that the cement was still in place, securing these teeth over the long term, which is why I like using these materials. So I prepared the cuspid and the bicuspid. I extended the provisionals over. I made a new set because the other ones were just so stained and dirty. And going again with the same issue of some pink acrylic in that area. And I pleaded with the patient, you know, we're lucky. You've come this far with these provisionals, and we haven't really gone backwards. Please return in 1 week. Let's continue treatment. And she did. So I was able to place new provisionals, and here you can see the bicuspids are in a much better angulation. Pulled off the temps from the lower, and you can see after 3.5, 4 years, the cement is still patent, even though that temp was worn down to the level of that cusp tip. So made a provisional on the right side, made a new provisional on the left side, and polished up the provisional on the in the anterior segment, and started to address the upper first quadrant. And I noted that even though the bone looked reasonable on the radiograph, there was probing depths that needed to be addressed. These teeth were heavily restored with resin. So flap was raised, and this is how you could get fooled. The crestal bone was fine, but there was a deep bony defect in between the teeth. So I've just outlined where the ostectomy was to take place, and that was done probably by way of rotary instrumentation in a slow handpiece, and probably using a number 15 scalpel to chisel and flip some of it away atraumatically. And provisionals were made at the same time. I had thought about root resection at this moment, but I thought, let's just see how skin healed. And it healed quite nicely. And we did the same thing on between the molars in the upper left, and that proceeded uneventfully. So starting in 2006, by the time I got to 2014, I finally had stability of the occlusion. And there you can see it. So by late 2014, I finally felt I had control. I've managed to stabilize the occlusion, which was a great event. And now restoring these teeth, restoring the dentition, I like to do these large cases segmentally. So if I've got provisionals all the way around, I'll start restoring a segment at a time because that's manageable. You have good landmarks of the provisionals to hold the occlusion, particularly in a bite like this where it's very deep overbite and the lower anteriors are nearly hitting the palate. So the first call was to get the upper anteriors under control. Going back to the previous posts, I rely on a cast post core. And you can see there it is with all the ferrule that I've been trying to preach in the last couple of posts about cast post cores. So that's secured tooth 21. Impressions were taken, making sure that they're defect free and perfect, because that will go a long way to giving us restorations that won't leak and break down over time. And the case was returned. I was thrilled. They mimicked the little bit of pink porcelain. I put that in the mouth. I thought, boy, cuspid provisionals, this looked great. And then I stepped back and I said, uh-oh, not so great after all, because this smile is canted and doesn't follow the interpupillary line. And this is probably a result of so many problems to manage intraorally that I just didn't see the forest for the trees. So I had lengthened out this cuspid. This is a temporary, so I was able to apply some new resin. And I took this picture, made this note, and sent it off to my lab technician. Making cuspid temp longer. Not your fault, but the smile line is not harmonious with the interpupillary line. I have lengthened the cusp, should have been the cuspid a bit, took a pickup impression. Can you please add as indicated? And drew my little white line. The case came back, put it in, took a picture, and again, going back and forth with the lab technician. These two final crowns were about 1 millimeter too long. Did not take a photo, but I did trim them to match the temps as shown here. So when you have good temporaries, you can use them as a guide to know if your lab or if you have nailed down the anatomy which you had envisioned and worked so hard in your provisionals. Took this and then this was all going back and forth to the lab tech because I was thrilled that this worked out as well as it did. I then had to trim the slightly longer mesial corner of 21. In the end, it looks spectacular. Sorry, I forgot to take a photo of the cemented case, but it matches the smile line. Thanks. And details. So again, I don't like having porcelain in embrasure spaces such as that. My hygienist can't clean in between there, neither can the patient. That will be a source for constant concern. So taking sandpaper discs and carborundum discs, I managed to just feather away some of that porcelain and expose a good clean metal margin, which adapts quite nicely. And there it's the completed case. And everybody, including the patient, was thrilled because she could finally smile with confidence. This was a rather emotional day for the both of us. And then once the upper anteriors were secured, go ahead and work on the first quadrant, and you can see the periodontal surgery that was done. Looked perfect, skin was tight, no probing. So I elected to leave that distal buccal root rather than do endo, resect it, and just incur more work and more costs. I would have if it was indicated, but in this case it wasn't. 4-unit bridge, double abut the molars. I don't like having a singles here because you can put this in and then at a later date, this can drift back, and I just want the security that I've strapped everything up and nothing will move. So this was April 2015. This little bit of bleeding is just a result of trauma that's incurred removing the cement. and the case was cemented in uneventfully. I didn't see her for a year. She had another family medical issue, but I mistakenly or inadvertently had cemented some of this work in with Tempon rather than polyF cement. So we did get a little bit of recurrent decay after a year. Thankfully, the 26 and 27 were fine, so 2 splinted crowns were made. And then we addressed the lower 4th quadrant. The teeth here were fine, so went ahead and restored that, and the orthodontics just looked beautiful. I never needed to take apart this complex that was done back in Poland. It seemed to be holding up quite nicely, and the 4-unit bridge was made and inserted. But when I got around to 235, my heart broke, because what I wanted to do was maintain segments. I wanted to restore just the 3rd quadrant separately, using 34, 35, going back to the molar, and then have the anterior segment separate. It's just easier and less technically demanding. But I could not leave that as a sole abutment or even double abut. I decided I would strap everything up if I could keep that tooth. So periodontal surgery was carried out, and if I felt that I couldn't do that, I would just have extracted the tooth. So I might as well take a little bit of bone away and see if I can get enough ferrule, because she has to go through this anyways. This is far less traumatic than extracting the tooth. So opened it up. I was able to define a margin, took the 2 separate bridges, and with methyl methacrylate powder liquid resin, you can tack it together because, as I've said many times, it adds to itself an infinite number of times, no matter how old the substrate is. Then just picking up a wash of the margins and trimming that down so everything fits beautifully and as atraumatically as possible, because I want healing to occur uneventfully, and I don't want any irritation from provisional bridge work. There's a radiograph of that tooth, and indeed, the tissue did heal quite nicely, and I decided we're going to keep this tooth. Again, indirect technique for a cast post-core, and in this case with a marginal apron, because there's so precious little left above the crest of bone. And there it is cemented in. Tissue remained pink, healthy, no bleeding in this area. Standard VPS impression to pick up the impression of what's remaining. I get all bridge work back in segments and then do solder indexing intraorally, and you can view some of the other posts to see how this is done. In a case such as this, I want the metal framework back soldered without porcelain so I can see if indeed the fit is good in the mouth, that there can't be a hint of a rock, or I'll just slice it and do it again. And the bridge fit very nicely, very passively. The porcelain is processed to the metal, and the case is cemented in. And there you can see it. So started in 2006 when I first saw the patient, and some 11 years later, we finally got around to finishing the case. And throughout, she managed to function. Before and after. The foundation has to be solid, and that was addressed, making sure that everything was spot on. And you can see that why I elected never to try to redo these endos. The bone just looked so good. There was no periapical pathology. Could I get some later on? Sure, but it's a risk. It's a risk I was willing to take, because the risk of trying to retreat this and lose it, I would rather live with the risk of trying to sort this out at a later date. Again, before and after. So all the margins are spot on, and everything was addressed in a proper sequence. So key points I'd like you to take away from this presentation. And from Plato, a good decision is based on knowledge and not on numbers. And sometimes you have to rely on your clinical experience, what's worked in the past for yourself and for others. And you have to be honest with that. Life is messy. A big problem is a composite of many small problems. Endeavor to have a large toolbox so you can deal with all of the problems as they arise. Try to get as many techniques as you can down in a competent fashion. And yes, providing excellence in dentistry is a tough gig. It's not easy. And you have to acknowledge the frustration when it occurs. And sometimes it occurs with patient management. But you have to stay the course and must always put the patient's needs above all else. Because, also from Plato, be kind, for everyone you meet is fighting a hard battle. And she was fighting battles on the home front, and you have to be respectful of that. And in this case, I had to work around it. I had no choice. And from that other great dental sage, Palto, teeth in a day, really? Here are some truisms I'd like to share with you. There's nothing more dangerous than a dentist back from a weekend course. Even worse is a dentist back from watching an online presentation, thinking you could solve the world. Whenever I go to presentations and lectures, it's my hope to pick up just one or two tips, one or two points, and integrate them into my habitual protocols. Then carefully, patiently assess their efficacy. My presentations rely heavily on photographs because I'm a visual learner, and I assume that many of the viewers are as well. So try to digest what I've presented. Don't change whole hog what you're doing. If there's some small tips you can pick up, that's the way to integrate them slowly. It's my hope that these posts provide insights to young clinicians when they stumble upon similar problems I have managed. And with that, thank you very much and good luck.